Welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting head and neck imaging case of the day. As I always like to start out by saying that all of the educational content found as part of this presentation has been completely de-identified in order to protect patient privacy. So today's case is a patient who came in to be imaged for chronic bilateral hearing loss. So I have two images for you to look at. Both of these are coronal non-contrast bone CT images obtained as part of a temporal bone CT. The image on your left is the patient's right temporal bone. The image on your right is the patient's left temporal bone. So keep in mind that clinical history, this is a chronic bilateral hearing loss. Take a look at the imaging, try to piece this together and figure out what you think is going on. Okay, so now that you've had a few moments to take a look at the imaging, what's your most likely diagnosis here? The follow-up question is, do you think this patient has a conductive or a sensorineural hearing loss, and why? And then take a step even further back, and what might this patient's past medical history contain? All right, let's take a look at the imaging. First up, I'm only going to show you one of the temporal bones because it's the same exact finding on both sides. So whatever you see on this side is the same on the other side. But what you should notice, and where the yellow arrow is pointing at, we have a crescentic soft tissue plug that's deep in the external auditory canal. It's within the bony segment or the osseous segment of the external auditory canal. Now, if you look right where the tip of that arrow is at, you can see this has a concave outer margin. And that's something that is maybe not 100% reproducible with this, but it is an important feature that is oftentimes seen with this diagnosis and may help you a little bit in trying to decipher whether this is something else going on, one of the other potential differential diagnoses. Now, as you take a look at this, you can see that the soft tissue plug is really inseparable from the tympanic membrane. In fact, we can't even identify where the tympanic membrane is at, other than we can say with high confidence that this process is not extending into the middle ear. In fact, the middle ear looks completely aerated from what we're seeing here. Now, an even more important finding to note is we do not see any destructive bone changes or any osseous remodeling of the external auditory canal. So while that concave outer margin is certainly an important finding, an even more important finding is to look at the bones. Make sure you look at the bones in these cases. We don't see any destruction, any erosion of the external auditory canal, and we don't have any remodeling of it either. So put all that together. Chronic hearing loss, bilateral. We have these soft tissue plugs sort of deep within the external auditory canal. Concave outer margin. Don't see any bone erosion, don't see any bone destruction, really don't see any bone remodeling or expansion or widening of the external auditory canals. So what do you think might be going on here? What's your top diagnosis? So this is a case of medial canal fibrosis, and this occurs because there's a pathologic formation of fibrous tissue along the medial or the deep aspect of the osseous external auditory canal. Now, this can be thought of as the end game of multiple potential etiologies, and that's what I wanted you to think about here is what potential past medical histories might this patient have had. So the most common is in patients who have chronic otitis externa. But you can also see this in the setting of suppurative otitis media, in the setting of trauma, and sometimes even iatrogenic in etiology, whether they've had prior surgery or radiation. It's not exactly known. There are some who have speculated that there may be an autoimmune component to this as well that maybe sets patients up for developing this prolific fibrous tissue deposition. But regardless, this results in conductive hearing loss, and that's because we have effectively put a plug of something into the external auditory canal, and that prevents those sound waves from entering. The whole purpose of the external auditory canal and the external ear are to effectively act as a funnel to help direct those sound waves, that acoustic energy, toward the tympanic membrane. And in this case, we've put a plug in there. So it's a physical barrier that's keeping those sound waves from bouncing off the tympanic membrane. It's dampening that conduction of sound across the tympanic membrane We can no longer use the tympanic membrane and the ossicular chain as a transducer. And again, I want to stress that on imaging, we don't really see the tympanic membrane because this is right up against it. In fact, it's indistinguishable on imaging. So you can see that close approximation to the tympanic membrane, and it makes sense that this is going to impair the conduction of sound. Now, the critical thing that you need to be looking for is whenever you see soft tissue opacifying the external auditory canal, look at the bones. The bones tell the story. Do we see destructive bone changes? Do we see sort of benign remodeling of the external auditory canal? Well, in this case, with medial canal fibrosis, we see neither. This is typically treated early on with steroids. It has a so-called wet phase or an early phase, kind of this inflammatory component early on. If they hit it hard with steroids, the idea is to try to knock it down. But in patients who present sort of end game like this is the so-called dry phase or the late phase. These patients are going to require surgery in order to open that external auditory canal up, so they may end up getting a meatoplasty and a canalplasty. So this is just a nice paper. It was published in 2017 in the Laryngoscope, and this is a meta-analysis of looking at sort of the short and long-term outcomes of patients who have post-inflammatory medial canal fibrosis. So it's an interesting and pretty quick read, and I would recommend it to all the residents and neuroradiology fellows out there. Okay, so let's wrap this case up. This again was a case of medial canal fibrosis. The key imaging features that you need to recognize, first of all, look for that crescentic soft tissue plug deep within the bony external auditory canal. This is going to be inseparable from the tympanic membrane on imaging, but it should spare the middle ear. And importantly, look at the bones. There should be no associated bone remodeling or erosion of the external auditory canal. Now, there are some pitfalls to keep in mind. Again, look at the bones. I think the bones are critically helpful in this case, and they'll help you to differentiate from some potential other etiologies of soft tissue external auditory canal lesions. So for instance, an uncommon diagnosis, but something that we see from time to time, are external auditory canal cholesteatomas. These should have erosion of the bone, and oftentimes it leaves behind these little bone flecks within that eroded, scalloped out component of the bony external auditory canal. So we don't see that with medial canal fibrosis. Keratosis obturans can look an awful lot like this as well. This is something that it may, not always, but it may, as it progresses, sort of have this smooth osseous remodeling or widening of the external auditory canal. This less frequently has that concave outer margin, but again, that's an imperfect finding. If you see an expanded external auditory canal that's got a soft tissue plug within it, but nothing that looks like eroded or chewed up bone, be thinking about keratosis obturans. And then don't confuse this for cerumen. Cerumen, or wax that gets built up in the external auditory canal, usually has much more of a lobular look, tends to have little air clefts within it as well. You know, I suppose you could have a terrible cerumentous impaction that just got crammed in and can look like this. And that's really something that they can quite easily distinguish on otoscopy. Well, as always, thanks for tuning in to IU Radiology Case of the Day, another interesting head and neck case this week. I would invite you to follow along on Twitter at NAKuntz, and invite you to check out the complete collection of IU Radiology Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.